Okay, so the first slide is my title slide. Go ahead and switch to the next slide. So just my conflict of interest statement that obviously I do some speaking for Zomedica, and I also have previously done some speaking for Merck Animal Health and PRN Pharmacal, and I've had some research sponsorship by Merck Animal Health. In fact, most of you guys, if you've ever heard me speak before or seen much that I've written, it's usually about urinary tract disease. However, I also have a significant interest in endocrine disease. I just have not been brave enough to jump out there in with all of the like amazingly smart people who do endocrine work. Okay, next slide. So we're going to skip this slide because it's a slide that's more than you need to know. We're going to move to the next one. It says pituitary gland. So remember, the pituitary gland has three parts: the anterior lobe, the intermediate lobe, and the posterior lobe, which I'm sure we all had to memorize at some point for some sort of an exam we took. But we're looking at the anterior lobe, which has growth hormone, ACTH, TSH, LH, and FSH. And this is actually the one where we see most of our pituitary tumors that cause Cushing's disease, because that's where the tumors originate that secrete a lot of ACTH. Next slide. The HPA axis. So the important thing about this whole process to remember is that the hypothalamus produces CRH, corticotrophin releasing hormone, which is stimulated by low cortisol levels, low blood sugar, fever, and stress. Okay, so that's where all of those things feed into. That CRH tells the anterior pituitary to produce corticotrophin, which we know as ACTH. So that's endogenous ACTH that is produced. And the endogenous ACTH then tells the adrenal gland to produce cortisol and angiotensin, aldosterone, some other things, but primarily cortisol. And then the cortisol is released and does all its wonderful things to keep us balanced. But it also, as every good endocrine system has a negative feedback loop so that we aren't like constantly stressed all the time, like FIC cats, because of course I had to bring a lower urinary tract problem into the discussion. You can roll your eyes or giggle, whichever you're feeling. But the cortisol actually has negative feedback impacts on both the anterior pituitary and the hypothalamus. It also has a local negative feedback onto the adrenal gland and tells the adrenal gland to turn off the cortisol. It tells the anterior pituitary to turn off the ACTH and tells the hypothalamus to turn off the CRH, so that we aren't walking around like big balls of stress and cortisol hormones all the time. Next slide, please. Can you just tell me, by the way, when you switch?
Yes, Emma can do that.
Great. Okay, so this is pathophysiology of hypercortisolism. And there's a lot of endocrinologists who argue about whether you can call it hyperadrenocorticism or hypercortisolism. Hypercortisolism technically is actually the right term, but we all know what we're all talking about. So in panel A, you can see that normally when you have ACTH secreted, it triggers cortisol, which then has negative feedback, as I mentioned before. And when it goes up, excuse me, when you have a tumor in the pituitary, like a microadenoma that is secreting excess ACTH, that's the most common type of Cushing's disease that we see, you will get excessive cortisol release from the hormone or from the adrenal glands. And like any good gland that's being worked out quite a bit, it's going to actually increase in size. So you get larger adrenal glands that way. And because the ACTH is coming from a tumor, remember, tumors are like the honey badger. Tumor don't care, right? Tumor doesn't care about negative feedback. Tumor's ignoring all that. Tumor going to do what it wants to do. Now, these are microadenomas. They're very small, but they're still pretty powerful. And they don't care that all that cortisol is running around the body and telling it to turn off because, you know, microadenoma don't care. So that's the most common type of hypercortisolism that we see. The second type we see is when you have an adrenal tumor that's producing just a lot of cortisol. And that actually will have significant negative feedback to both the pituitary and the hypothalamus. So when that happens, because the pituitary in these cases is normal, you're going to get a low ACTH level, but still tons of cortisol, and that's all feeding negatively back. And then you get one adrenal gland that either looks really big or is not very big, but then has a big old knobble tumor on this end of it. And the other adrenal gland is actually going to be small because the cortisol is being produced. It's actually going to have negative feedback onto that adrenal gland. Next slide.
It's up, Julie.
Thank you. So the hypercortisolism causes increased protein breakdown, causes muscle wasting, increased fat synthesis, so hyperlipidemia and central obesity, and interference with ADH, antidiuretic hormone, which is what happens when we have central diabetes insipidus, where we have lots of ADH produced, or no ADH produced, sorry. ADH is important to hold back water, and if that is being interfered with by the cortisol, the body cannot hold back a lot of water in the kidneys. And so that's what leads to the PUPD we see with these patients. That central obesity, along with the muscle wasting and the hypertrophy of the liver that we get, all leads to that classic potbelly dachshund that we think of. The abdominal muscles are weakened, the liver is big and heavy and pushing down, and that's what leads to all of that. Next slide.
Go ahead.
We can also see lowered thyroid. So be careful in a patient you think looks Cushionoid about testing the T4. And if it is low, you need to ignore it because cortisol will actually artificially depress the T4. The patient may show signs of hypothyroidism, but the reality is it's just because of the cortisol. And if you address the hypercortisolism with treatment, you're not going to have the T4 be as low. It's going to come back up to normal. Patient's going to be fine. You don't have to supplement these patients with thyroid hormone. You're also going to have increased hepatic glycogen deposition, which is basically like stuffing the liver cells with glycogen. And that's where you get that hepatomegaly, the increased alk phos, and you get a secondary mild ALT increase. Next slide.
Go ahead, Julie.
So we tend to speak of Cushing's disease as PDH or ADH. PDH being pituitary-dependent hypercortisolism, where you've got that pituitary tumor, and ADH being where you have adrenal-dependent hypercortisolism, where you have an adrenal tumor. 75 to 80% of our patients with pituitary-dependent hypercortisolism have an adenoma, meaning not malignant, but a benign tumor in the anterior lobe of the pituitary. So those tumors have impaired response to that cortisol feedback. So they're, again, honey badger don't care. We're not going to turn off, okay? But usually the response is only partially impaired. If you give them enough of a push of cortisol, they'll oftentimes shut down a little bit. And this is going to be really important later when we talk about high-dose dexamethasone suppression tests. 20 to 25% of them have adenoma in the pars intermedia, so in a different part of the pituitary. These guys really do not care about that negative feedback. So those guys actually completely ignore even very high doses of cortisol that you can give them. And so they will almost test like an adrenal tumor. And this is why both low-dose dex and high-dose dex are not 100% perfect about determining whether a patient has an adrenal tumor or a pituitary tumor, because this quarter of patients may actually have a tumor that will ignore cortisol even more than most of the pituitary patients. Next slide.
Go ahead.
The pituitary adenomas are usually small, which is why we call them microadenomas, or large, called macroadenomas. Macroadenomas are less common. They tend to be the pars intermedia ones, and they actually can be very challenging to control. They're kind of like those diabetics you have that we call brittle diabetics, where you give them a little bit more drug and they crash, and then you give them a little less and they do fine. And so it's very challenging with the macroadenomas because they also tend to be more sporadic in the amount of ACTH they secrete. But overall, increased ACTH secretion leads to increased secretion of cortisol from the adrenal cortex, and it may lead usually to bilateral hypertrophy of the adrenal glands. But actually, some adrenal glands don't get as big as you think they do, even with pituitary-dependent hormones. Next.
Go ahead.
So the adrenal tumor cases, usually it's an adenoma, benign, or adenocarcinoma, meaning malignant, on one gland. Occasionally you'll see two, but it's pretty uncommon. I've only maybe seen 1 or 2 cases in 25 years of practice. They have an independent secretion of cortisol, and because they have all that negative feedback to the pituitary, their ACTH levels are actually low. The cortisol levels are also not suppressed by high doses of dexamethasone or other steroids, because these are the honey badgers who really don't care. They're completely ignoring any sort of negative feedback. Oftentimes, the other adrenal gland is normal or a little bit small with an atrophied cortex. Next. So you guys know middle-aged to older dog, rare Cushing's if they're under 6 years, small dogs more than large breed dogs, but any dog can get it. You guys know the breeds: poodles, dachshunds, terriers, beagles, German shepherds. Larger breeds may have a higher risk of adrenal tumors than small breeds, but overall pituitary dependent is the most common. Next.
Go ahead.
So you guys know all of these different things, but the big thing is the top two. 85% of these patients are PUPD and 90% of them are polyphagia. Those are the two major things that we see in our patients. Next. Most of these really classic signs, like the really thin skin, the calcinosis cutis, we're not seeing as often now because we're smarter than we used to be, and we're actually recognizing and diagnosing them earlier than we did before. Next.
Go ahead.
They're also usually not sick. So if you have a patient, you can hit to the next slide. If you have a patient that has vomiting, diarrhea, anorexia, coughing, all these things, even if you have PUPD with these patients, I'm not saying they don't have hyperadrenal, but something else is causing the vomiting and diarrhea and anorexia. These patients are usually not sick if all they have is Cushing's. And patients with Cushing's disease don't usually die in the acute phase. They're more chronically ill. If you have a patient who's more of a chronic vomiter, even if their alk phos is elevated, the vomiting is not being caused by Cushing's disease. You need to look for something else. And it's really not a good idea to be doing Cushing's disease testing on patients who have any of these clinical signs, because the worry is you're not actually going to get an accurate diagnosis because they have something else going on you have to address first. Next slide. We actually had one of these this week in our hospital. An anorectic vomiting dog who we suspect is probably Cushionoid, but we're like, that's not the reason this dog is sick. Like, it might have pancreatitis, but we need to deal with that first before we go testing it for Cushing's disease. So on our blood work, you're going to see a high alk phos. 95% of them have a high alk phos. And the level of the alk phos does not actually have any correlation with the severity of the disease. That's a really important point. 85% of them have isostenuria. 50% have a low T4, but again, clinically, they are not actually hypothyroid, so you don't need to supplement them. A lot of them may have a high cholesterol as well. They might have a high glucose. We know that having Cushing's disease increases the risk of developing secondary diabetes. They may have a low potassium. If they do, it's mild, and it's mainly because of their PUPD. And they usually or may have a stress leukogram, meaning mildly elevated mature neutrophilia, mild lymphopenia. Next slide. So alk phos, its point is to catalyze hydrolysis of phosphate esters. There are three major isoenzymes, as you remember. The liver is the major one we see. Bone, which is why young growing animals have elevated alk phos. And then the steroid-induced one. CALP is what we call the steroid-induced one. And if you have a lab that actually runs a CALP for you, some people will diagnose Cushing's based on that, but you have to be careful. It's very sensitive, but it's not specific, meaning there's a lot of reasons that the CALP can be elevated. Even a period of stress like going to the groomers or being boarded can make it go elevated. But the majority of Cushionoid dogs have a high CALP. So if you have an animal that does not have an elevated corticosteroid-induced alk phos, and you have that on your lab work, and you're suspicious this patient may be Cushionoid, then I would lower that suspicion and start looking for other reasons that might be PUPD. Next.
Go ahead.
One other thing to remember is that, you can hit the next slide too, is that phenobarbital will increase the alk phos. So if you have a patient who's taking phenobarbital basically mimics steroids in a lot of ways. It will make them PUPD, it will make them polyphagic, it will make their liver get big. And so you just have to remember that if they're on that particular drug, it will actually interfere with your numbers because it's going to make the alk phos look elevated. Next slide.
And I think we need to go one more.
Vacuolar hepatopathy is what this one says.
Is this the right one, Julie?
It says vacuolar hepatopathy.
Yes.
Okay, so now vacuolar hepatopathy is the other thing that throws a wrench in all of our difficulties. These are those cases that for years, some of you who are among my generation remember being people saying it's atypical Cushing's, or that phrase people used to say because it has an elevated alk phos. But the animals oftentimes are not PUPD and not polyphagic. They might have a little bit of a big liver, but there's nothing else that's really yelling at you. They may not have evidence of adrenal illness. It's usually in older dogs, but they've got these alk phoses in the 600s and 700 levels. And you're like, well, something has to be going on. And when you biopsy them, they come back consistent with steroid hepatopathy, which is basically vacuolar hepatopathy. But their adrenal glands look normal, and if you do adrenal testing, it's normal. So it's a very poorly defined syndrome, but we're calling this vacuolar hepatopathy. I actually have a whole lecture I call Chasing the Alkaline Phosphatase about this, because we just don't know what causes it, but it doesn't actually require any treatment. You can certainly go ahead and test for these, but if the Cushing's test is negative, you need to believe it and think, okay, especially if they don't have a lot of the other clinical signs we see with Cushing's disease. And currently, there's no evidence that these patients will go on to develop Cushing's disease. So that's another important thing to remember, that if your tests are negative and the animal doesn't completely fit the position of Cushing's disease, but the alk phos is high, you can't just believe the numbers. You have to believe what the animal is telling you. Next slide.
Go ahead.
So for testing options, what are our things we can test for diagnosis for Cushing's disease? You can do a urine cortisol creatinine ratio, which is great. I love those. The owner takes a urine sample at least a week after any stressful event, including a visit to your hospital. So don't be taking the urine when the animal's in your waiting room. And they drop it off because cortisol is very stable in the urine. They can drop it off at your practice, and you send out a UCCR. And what that does is it tests the amount of cortisol the animal's dumping into the urine. And ideally, we do it as a first morning urine sample so that it's after a nice, quiet night of sleeping. This is best used for patients where you have a low index of suspicion. So you've got a PUPD animal, their liver, or let's say their kidney values are up a little bit, their liver values are up a little bit. You're just trying to rule out Cushing's and take it off the table. That's a great use of the UCCR. Then you can, if that's one where if the UCCR is normal, that patient does not have Cushing's, meaning they are not dumping enough cortisol into their urine to have Cushing's disease. If it's elevated, it doesn't say definitively the animal has Cushing's. It says now I need to do a more specific test. They could have Cushing's. And the next step after that would either be an ACTH stimulation or a low-dose dexamethasone suppression test. There is a test called the LDD, low-dose dex suppression test, and UCCR. We haven't really developed protocols that are well enough defined for that, so I'm not really going to address it, but you might read about it in journal articles. Primarily today, we're going to be talking about low-dose dexes, high-dose dexes, and ACTH stems. Next slide.
Go ahead.
Then, if you determine a patient is Cushionoid, the next step is to say, well, is it a pituitary dependent or is it adrenal tumor? Because if it's an adrenal tumor, I could actually send this to a surgeon and have that adrenal tumor removed and potentially allow for a cure in this patient. So that's certainly something that we would like to be able to do. So the next step is a high-dose dex suppression test. And that takes advantage of the fact that those adrenal tumors completely don't care about any high levels of cortisol that are given, but most of our pituitary dependent cases with very high levels of cortisol will actually suppress. So that's one thing that we will do. Remember, those pars intermedia adenomas sometimes also ignore even high doses of cortisol. other things that we can do to determine whether it's pituitary or adrenal. We can do imaging. We can do ultrasound or CT or MRI, mainly ultrasound or CT, looking at those adrenal glands. Do you see a tumor on one? Are they both about the same size? What are we seeing? And then we can also do an ACTH level, because if it's an adrenal tumor, the ACTH level is going to be suppressed and low. If it's a pituitary tumor, the ACTH level is going to be high, because that's where the source of the problem is. Now, we didn't used to do this very often. I'll explain why in a little bit, but now we actually might have it available to us, which is wonderful. So looking at a urine cortisol creatinine ratio, as I mentioned before, next slide, it is 75 to 100% sensitive, meaning if the patient has Cushing's, it's going to be abnormal. But specific-wise, if the patient has Cushing's, if the patient has other diseases that cause stress in the body, like diabetes, it's also going to be elevated. So it's not really the greatest. Next slide. The ACTH stim test is 85% sensitive and 85% specific. It's really great, actually, we all know, for diagnosing Addison's. It's also pretty decent if we're giving a bunch of prednisone to the animal and wondering whether or not we're making them have all these Cushingoid signs. Most of us don't do that. We always just acknowledge that I'm giving the dog a lot of steroids because of its skin disease or cancer or whatever, and so I know that it's going to have these side effects. But what you'll see is that the adrenal glands are suppressed, and so when you take a cortisol level, give them synthetic ACTH, and then take another cortisol level an hour later, the adrenal glands can't respond because they've been suppressed by all of the exogenous or external cortisol that you're giving them. If you have an adrenal tumor, however, they can respond any way they want. They may increase or they may stay flat. It's actually very challenging to use an ACTH stim test to diagnose an adrenal-based tumor. Next slide.
Go ahead.
In contrast, a low-dose DEX suppression test actually has about 95% sensitivity and 73% specificity, meaning you will pick up almost all of the cases that truly have Cushing's, but you may have some patients that that don't have Cushing's that will still test positive. So that's one of the things you have to kind of think about. When we are, just like any of our diseases that we all know by this time, when we're looking, we don't just look at the test results. We have to think about the whole patient. We have to think about other things that are wrong with them, what their clinical signs are, what their blood work is telling us, and you have to put all of these pieces of information together to decide how much you believe the test results. Now, when we do a low-dose DEX, the negative part about it is it takes 8 hours. ACTH stims only take 1 hour, but low-dose DEXs are a little bit better as a test. If suppression, so we think, okay, you take your initial pre-cortisol level, and then you give them a low dose of dexamethasone, and what you want in a normal animal is for the adrenal glands to suppress secretion of cortisol at 4 hours and at 8 hours. If they don't suppress, the animal has Cushing's disease. What we get confused about sometimes is if they suppress at 4 hours, but then they jump back up at 8 hours. Now, what do we do with that? Well, in that situation, actually, it is more likely they have Cushing's, but it's most likely that they have pituitary-dependent Cushing's. If there's no suppression and they're straight across the top, then they either have an adrenal tumor or they have one of those pars intermedia, honey badger don't care, pituitary-dependent ones. What do we consider suppression? Suppression is, traditionally we always thought, okay, suppression is like less than 1, right? Actually, suppression is more than 50% of the baseline. So if you start out with a baseline cortisol of 8 and it suppresses to 2, it's not less than 1, but it's more than 50% down from what the original level was. So that is considered suppression. And that's one of those things that I never remember learning until much later in my career. And it's an important piece, and actually probably more important than the suppress less than 1 part. So that's one of those things, one of those key points I really want you guys to take home tonight. Next slide.
Go ahead.
Let's actually skip this one and skip the other tests and go to the one that says other tests plasma ACTH level.
There we go.
Okay, so I mentioned before, you could just do an ACTH level. Why don't we do that? It just tells us whether it's coming from the adrenal glands or the pituitaries. Well, the problem is ACTH is extremely labile and degrades really fast. So that's one of the reasons why we never really used it. You can't ship it. Only a couple labs in the country will run dog ACTH levels. And it degrades so fast that the few times I've run them, I've always sent a normal dog's blood along with it, so I would know whether it degraded. Because if they both come back with none, then I'm like, okay, well, obviously that was a fail. The good thing is now we actually have the potential to perform an endogenous, that's the E, ACTH in-house right when you draw the blood from the animal. And that's one of the real benefits of the TRUFORMA platform, is that it actually will measure in your hospital the ACTH. So you don't have to worry about the shipping and handling issues. You don't have to worry about all that stuff. Next slide.
Go ahead.
So how do I choose which test I'm going to run? So index of suspicion. If the animal's signalment and clinical signs are all pointing towards Cushing's disease, then I probably would not run a urine cortisol creatinine ratio, because that's really more of a rule out test. That's when you have the PUPD animal that doesn't have a lot of other things that are making you think Cushing's. You just want to basically cross off your list. It's an inexpensive test. It's easy to run for the owner. They just grab some pee at home and drop it off. So that's when I would choose that one, is if you really don't think it is. If you have a high index of suspicion, then you have to think, well, do I have colchicine in-house? That's one thing, is that a lot of people don't carry it. If you don't see a lot of Cushingnoid patients, you aren't going to keep it around because it's not cheap. You have to buy it in batches of 10 bottles. We know we can aliquot it out and freeze it, and it lasts for a couple of years that way, but still, some practices don't have it. So if you don't have it, then you do index SP. We also know that ACTH stims, which use the colchicine, are not quite as good for diagnosis as a low-dose dex. And then you have the convenience issue. An ACTH takes an hour. A low-dose dex is 8. That means the owner drops the animal off when you guys open and picks it up before you guys close. So it does mean, and it's also 3 cortisol levels that you have to send out. So it's actually, the cost-wise, they're about the same, because the cost of the colchicine, we all know Dex SP doesn't cost anything really, it's pennies. But the colchicine cost actually is equivalent to that 3rd cortisol level, usually when you send it out. So the cost difference really isn't that much. Next slide. So what I mentioned before, that if the animal has a non-adrenal illness that looks like hyperadrenochromatosis, but it doesn't really have that, the higher risk you have of a positive result on testing. Diabetics will test as though they're positive for Cushing's disease, even if they don't have Cushing's disease. So just a reminder. Next slide. This is just kind of a slide that tells you if you have a high suspicion, a low suspicion, which test you use when. So low suspicion, use a UCCR or a low-dose dex. High suspicion, do a low-dose dex, maybe do an ACTH stim. I prefer to use ACTH stims to monitor control. ACTH level is great to determine the difference between a pituitary or adrenal dependent, as is a low-dose dex, or a high-dose dex. And so I'm not sure if people are going to get copies of these slides, but this is a really good way to think about when you're going to use which type of testing. Next slide. Let's move to the slide that has the first chart on it. It says 11-year-old female spayed miniature poodle. We're going to practice a little bit here, interpreting some tests.
Go ahead.
Okay, I promised you guys graphs. So this is a low-dose dexamethasone suppression test. It's an 11-year-old female spayed miniature poodle. It's PUPD for a month. So you decide to do a low-dose dex. the baseline is 4.3, 4 hours is 2, and 8 hours is 3.5. So is this Cushing's or not? And if it is Cushing's, can you tell whether or not it's pituitary dependent or adrenal dependent? Everybody, a few seconds to think about that. It is actually pituitary dependent because the drop at 4 hours was more than 50%. So that could have been true suppression, but then it escaped at 8 hours. And 3.5 is not more than 50% less than 4.3. So this escaped. Now, an adrenal tumor will not have that suppression at 4 hours. It would have been straight down to 3.5, okay? So the fact that you suppressed at 4, escape at 8, that's pituitary dependent. Next slide. We have an 8-year-old male castrated Yorkie with polyphagia and hair loss. We decided to do a low-dose DEX. 0 hour, 3.5. 4 hours, 0.8. That is a more than 50% drop. That is a suppression at 4 hours. At 8 hours, we have 2. Again, we suppressed at 4. We escaped at 8. This is pituitary-dependent hyperadrenocorticism, or consistent with it. Next slide. Case 3, we've got a 10-year-old female spayed doodle, because now we're seeing old doodles, with an alk phos of 700, and a low-dose DEX suppression test is what we decide to do. We start out with a baseline of 2.5. At 4 hours, we have 0.5, so that's suppression, more than 50% down from baseline. And at 8 hours, we have 0.4. So this animal suppressed. This animal does not have Cushing's disease. At least not supported by this test. Okay, next slide, 13-year-old dachshund. Now on this one, we have a 13-year-old dachshund with PUPD and an equivocal low-dose DEX. So we're kind of like sitting on that edge of maybe 50% suppression, or we're like, well, let's try maybe we're like, okay, we're thinking maybe it probably is Cushionoid. It looks Cushionoid, let's just go with it. Let's do a high-dose DEX in this case and see whether we think it might be pituitary or adrenal. Now the high dose, meaning we gave this dog a slug of cortisol, okay? You gave it 0.1 mg per kg of DEX SP. Baseline's 2.5, 4 hours is 0.5, so that's more than 50%, so that's suppression. And at 8 hours, we're 0.4. So we have suppressed at 4 and 8 hours. If we think this dog is Cushionoid based on the low-dose DEX, this animal has a pituitary tumor, not an adrenal tumor, because the adrenal tumor should not have suppressed at all. Next slide. We have a 12-year-old Labrador with PUPD and polyphagia. It's positive on an ACTH stim. So you do the ACTH stim, it stims to like 28 or something like that. You're like, okay, this dog has Cushing. And you say, well, does it have adrenal tumor or a pituitary tumor? So let's do a high-dose DEX and try and differentiate. 0 hour baseline is 5, 4 hours is 4.5, and 8 hours is 4. So neither the 4 nor the 8 hours suppressed. So what that tells you is that it's either adrenal or it's one of those pars intermedia pituitaries, which are not very common. The next step would be to either run an ACTH level, if you have the ability to do that, with our fun new machine that Zomedica has, or you get somebody in to come in and do an ultrasound, or you do an ultrasound if you have it in your practice, and you look and see if there's an adrenal tumor on one of the adrenals, or if they're bilaterally plump. Next slide. Now here's an ACTH stim. 15-year-old female spayed miniature schnauzer with a PUPD and alk phos of 690. And I'm going to do an ACTH stim now. So now we're looking for increases of the cortisol level. So at 0 hour, it's 6.8, and at 1 hour, it's 9. Now, usually we use a cutoff of anywhere from 15 to 18 as our level that we want to stim above in order for a patient to actually be Cushingnoid. So this animal actually does not have a test that is supportive of hyperadrenocoricism. Next slide. And now we have a 15-year-old Bichon mix with thin skin. They all have thin skin when they're 15, regardless of whether they're Cushing's, actually, in my opinion, but whatever. They're also start to go bald. And an alk phos of 980. And we're going to do an ACTH stim. And this dog's baseline is 6.8 at 0 hours and 20 at 1 hour. So this tells you that, yes, this dog potentially has Cushing's disease. It's likely that it does. It has clinical signs associated with it, especially if it's PUPD also, but it does not differentiate between pituitary or adrenal. Next thing to do would be either imaging, a high-dose DEX, or run that endogenous ACTH level. Next slide. What if we're not sure if it's ADH or PDH because our testing showed either straight across on our high dose or we didn't do a high dose DEX? How can we figure it out? You can look for a mass on the adrenal. You can look for masses on both adrenals, which is really rare. Or you can look and see whether the adrenals maybe look normal. Because if the adrenals look normal, but an ACTH stim or a low-dose DEX indicates Cushing's, it's probably pituitary dependent. Usually the adrenal tumors in the adrenals that produce Cushing's disease are going to be obvious that there's a mass on the adrenal gland. Next slide. Skip to the one that says ACTH level. So if we're unsure or we're not that great at finding and measuring the adrenal glands, which I personally as an internist am not, how can we tell? Well, we can look again, as I mentioned, at the ACTH level. We can determine whether it's coming from the adrenal glands or the pituitary, because the pituitary gland produces a lot of ACTH. Adrenal-dependent Cushing's disease, the ACTH level should be low. I'm going to skip these next couple slides just in the interest of time because I want people to have the ability to ask questions. I would like to skip to the slide that says endogenous ACTH labile hormone.
Go ahead, Julie.
Great. So this is a figure, actually it's from Zoetis. This is a figure that shows EACTH sample instability. So it shows 3 different dogs that had endogenous ACTH. E just means it's their endogenous ACTH as opposed to cortrosine, which you give them. And when they draw the blood, it's looking at a couple different levels. And you can see by 4 hours, this dog, the ACTH is declining very quickly. It degrades really fast. But for the first couple hours, you're good. Well, if you have to send this stuff to Colorado State or Tennessee or Auburn or whatever it is that you're going to be testing this hormone, you're not really going to get a realistic answer because this stuff degrades even at room temperature. It's going to degrade. You have to freeze it. You have to use special tubes. It's just a pain. And it would be so easy to diagnose these patients, differentiate between pituitary and adrenal if we have the ability to measure this. Next slide, please.
Go ahead.
And this is why it's actually really important that we have the opportunity now with the TRUFORMA. And TRUFORMA measures, this particular point of care machine measures T4, feline and canine TSH, and it also measures cortisol. So it'll do your ACTHs and your low-dose DEXs for you. But the cool thing is now they actually have an ACTH cartridge that came out that will measure that ACTH within 15 minutes, even less, of you drawing the blood from the patient. So you don't have to worry about the degradation, and you don't have to do a high-dose DEX. Once you diagnose the patient with Cushing's disease, you run an ACTH, a single blood sample. One moment. You don't even have to do the 0, 4, and 8 hours for a high-dose DEX, and there you have your answer. And it's really, it's quite a convenient option. So next slide. thank you all so much for bearing with me in my technical difficulties. I'm horrified by it. I apologize.